Hi, my name is Jessica O'Connor, and I'm going to be talking about two disorders, brief psychotic disorder and shared psychotic disorder. We're going to start with shared psychotic disorder, which, as you may know, is when somebody who's in close proximity to a person who's having symptoms like schizophrenia or any other delusional disorder is going to adapt those same symptoms or similar symptoms. It may also be referred to as folie à deux, which is the French word meaning two people who are both having a mental health crisis or disorder. It most frequently occurs between a parent and a child. So if the parent is schizophrenic or having any other kind of hallucinations or delusions, then the child might develop those symptoms as well, just from being in the same general vicinity as their parent. However, it can also occur in a group setting. So it might happen in a cult where you see that the leader is having hallucinations and their followers will start to have the same hallucinations that the leader is having. It can also occur not only in schizophrenia-like symptoms, but also with a disorder such as obsessive compulsive disorder. There was actually a case study where there was a child whose mother had OCD, and he started to have really similar obsessions and compulsions as his mother did. My goodness. So shared psychotic disorder was listed in the DSM-4 as its own disorder, but when the DSM-5 came out, they actually didn't list it as its own separate disorder, but they put it under the category of delusional disorders. So it's just lumped in with a bunch of other disorders at this point. Some risk factors include a history of neglect, obviously being in close proximity to somebody who's having mental illness, any kind of delusions, hallucinations, something like that. A lack of social interactions. So if they're only socializing with this person who is the primary who's having the disorder, then it's going to be really high risk for them, and they're probably going to get shared psychotic disorder, whereas a child who's going to school or going to daycare constantly and not as much around their parent or whoever is having the disorder to begin with, then they would be less likely to get it. Also is a history of psychotic disorders. So as we see, both genes and environment play a very big role in shared psychotic disorder. Treatment is fairly simple. So the first step might be to separate the primary and the individual members. So if the secondary who was getting the symptoms from the primary is separated from them, then they will probably stop having their hallucinations. Another way to do it is if the primary is being treated, so if they're getting medication or going to therapy and then they stop having symptoms, the secondary is likely to stop having symptoms as well. So as long as they're either separated or one of them stops having symptoms, then that is a pretty good way to treat it. Next, we will talk about brief psychotic disorder. So as you may know, it is also with schizophrenia-like symptoms. However, it only lasts between 1 and 30 days. So it won't last any longer than a month, or else it's no longer a brief psychotic disorder. It has an average onset age of about 30 years old. However, that's not a determining factor. Anybody at any age can get brief psychotic disorder. 30 is just the average. Anyone with this disorder is really likely to recover well after their period of time is over. And they will likely not have any long-term effects, and they can just go on and live a normal life afterwards. Risk factors can include severe psychological stressors. So any kind of trauma or big stressful events might trigger this disorder. In terms of treatment, it is pretty difficult just because there's a lack of research for this disorder. It's very rare. Not a lot of people know about it. So it is just really difficult to find treatment and find treatment that is effective. So I want to talk about this case study really quickly. It has to do with shared psychotic disorder, not brief, but it was about a 15-year-old boy who had no previous psychiatric history, no mental illness. He started spending a lot of time on the internet, withdrawing from his family and friends. They noticed that he was becoming really irritable, kind of anxious. He started refusing to have any water, any food. He didn't want to eat or drink, and some other behavioral changes as well. His parents decided it was time for him to see a professional, and at this point, his sister decided that she would check his computer, which she knew that he was using often. And what they found is that he had been communicating with an individual who referred to themselves as the mistress, and the mistress was giving him these really difficult tasks that he had to do, or else she or he said that they would punish the boy. And so she was saying, you have to email me twice within half an hour, or like you have to email me every half hour for a 48-hour period, or you have to go this certain amount of time without any food or water. And he did, and he complied with her. Then he started having his own delusions and hallucinations. And so what they decided is that once they saw the professional, he said, I don't want him on the internet anymore. We don't need to have contact with the mistress, and that'll probably be helpful. What they found is that within about 2 months of not having contact with these people on the internet, he started not having any more symptoms. So as soon as he was away from it, all his delusions and hallucinations ended, which is very helpful. And it also gives us a lot of insight into shared psychotic disorder, because as it's usually thought of, well, at least I usually think of it as being in a home or like close proximity, but like something more tangible than online. Whereas we saw in this case study, he was just talking to somebody over the internet. It wasn't even somebody he had a close personal relationship to. And so that really helps in terms of like what it is and giving us more information about shared psychotic disorder that we might not have thought of before. And it also lets us know, like, we have to be very careful and very vigilant if you do have a child or know someone with a child who is on the internet, because it's possible that this might happen to them as well. Some key takeaways: because of the nature of brief and shared psychotic disorder, it is possible that not many people who have it are actually looking to get treated. Especially if you have shared psychotic disorder and you're in a place where the only other people you're interacting with are also having the same hallucinations, delusions, compulsions that you are, you might not think that there's a problem, so there might not be any logical reason in your mind to go out and seek treatment if you think everything is fine. Like I said earlier, brief psychotic disorder is really rare. There's a lack of research to inform treatment, which makes it really hard for the people who are diagnosed or who are having symptoms. And even the treatment that they do have, it might not be very effective, and it's probably going to be very, very difficult for the patient and the provider. And also, like I said, when we were talking about that case study, awareness of these symptoms will actually be really helpful for us. So if you're aware of brief psychotic disorder, shared psychotic disorder, not only will it help the professionals to learn about what kind of intervention strategies they can use or what treatment they could do, but also for just the normal people who may see somebody who's having symptoms that are similar, you'll at least be aware and then know, hey, this is something that needs to be treated, and maybe you should go get help. These are my resources. Thank you for listening. I will see you in class.